Welcome to this educational video, brought to you by the Society of Mechanical Ventilation. Clinical Cases. ARDS.
We've been asked by some of our members to start making some clinical cases and go through their discussion. And today we're gonna be discussing ARDS. We'll start with a case discussion and talk about the diagnosis, pathology, etiology of ARDS. Also, we'll talk about the mechanical ventilation management and especially the role of PEEP and the modes. So those were covered before in details in other videos. So briefly, we're going to touch base on them, but you can go back, see the other videos about respiratory mechanics, PEEP, different modes of mechanical ventilation. And we'll try to stress about the prevention of ventilator-induced lung injury. Non-ventilator management adjuncts like proning, role of pulmonary vasodilators, and steroids also will touch base on it. So we'll start our case, 65-year-old male with this history of coronary artery disease, heart failure with reduced ejection fraction, hypertension, who present to the hospital sudden onset abdominal pain, found to have ruptured diverticulitis, intra-abdominal infection, peritonitis, and had to go to the OR emergently for repair. Patient was, of course, hypotensive on IV pressors before the operation and during the operation, and was sent to the ICU intubated. On admission, if you look at his X-ray here, you can see per the report, and unfortunately I see a lot of them, the report is pulmonary edema secondary to congestive heart failure. And despite that the patient is septic, patient was given diuretics. So he went to the OR and sent to the ICU, worsening hypoxia, and repeat X-ray is showing this. Always the question is, and it's a confusing part of, is that pulmonary edema, is it cardiogenic pulmonary edema from basically congestive heart failure versus non-cardiogenic pulmonary edema secondary to ARDS? Granted that the diagnosis could be sometimes difficult, but given the clinical scenario and the sepsis, probably in this case you should lean more towards non-cardiogenic pulmonary edema. Especially try to avoid diuretics in somebody who's in septic shock. So quick discussion about the definition of ARDS per the latest definition from the Berlin definition. They stress a couple of things: the timing within 1 week of non-clinical insult or worsening respiratory symptoms, chest imaging, bilateral opacities not explained by effusions, lobar or lung collapse or nodules, respiratory failure not explained by the cardiac failure or fluid overload. And in the past, when we used to use a lot of more pulmonary artery catheters, we used to look at the cardiac filling pressures and all of this to rule out cardiogenic pulmonary edema. The origin of edema need objective assessment. Here they removed the pulmonary artery catheters, they put an echo. The problem with this for me is a lot of patients have dilated cardiomyopathy, even the ones who don't have dilated cardiomyopathy and diagnosed with that heart failure with preserved ejection fraction. That having dilated cardiomyopathy does not rule out ARDS, of course. So it's more of clinical diagnosis, and there's no gold really standard or any to define, basically to differentiate between both of them. But in reality is usually pulmonary edema secondary to hydrostatic or cardiogenic pulmonary edema is usually on mechanical ventilation, does not really need the high driving pressures and the high PEEP and everything like this, because it's hydrostatic and usually improves with medication quickly, most of the time, even with non-invasive positive pressure ventilation, versus the ARDS, usually the ones who have require very high PEEP, etc. Anyway, they classified the ARDS into mild according to the PaO2 Fi2 ratio, with a PEEP above 5, moderate 100 to 200, and severe less than 100. Again, those are at minimum of PEEP of 5. Again, that's a problem because you can do recruitment maneuvers, adjust the PEEP, and the patient goes from severe to moderate or severe to mild, or if he's moderate, he can be, after you do prone him and adjust again the PEEP, he might not be considered ARDS at all. The pathology of ARDS, this is a very famous picture. Again, this is the left side, the normal alveoli, normal capillary. You can see the type 2 cells, and the alveoli is empty, just full of air, some macrophage here. And in ARDS, it's all inflammatory problems with hyaline membranes and capillary leak. You can see even destruction of the alveolar epithelium and the vascular endothelium. So all the alveoli from inside has a junk of fibrin and W white cells, sometimes platelets, some has all this inflammatory stuff inside the alveoli. Usually there's two types of ARDS, pulmonary versus non-pulmonary, versus meaning like is it a direct insult to the lung versus insult to the lung from a problem outside the lung. Like pneumonias, whether it's bacterial, viral, fungal, parasitic, aspiration of gastric contents, pneumonitis, pulmonary contusions, inhalation, fat emboli, those cause direct injury to the lung and of course expand to both lungs. Versus the extrapulmonary ARDS, like usually most common sepsis, trauma, drug overdose, pancreatitis, cardiopulmonary bypass, and much more etiologies than this. I think it's good to differentiate between both of them because most of the studies found that the extrapulmonary ARDS actually have better prognosis and usually are more PEEP responsive than the pulmonary ARDS. So we just intubated the patient, and as we know, it's an ARDS case. Um, how do we know? Just from looking at the waveforms, of ventilator waveforms. First, in the airway pressure, you can see it's very high peak inspiratory pressure. You can see that first part, which usually is resistance, is very low, but we'll talk about this more. If you look at the flow waveform, especially the expiratory flow waveform, you can see it's very deep, going down very deep, and immediately rebound quickly to the baseline, meaning that the lung tends to collapse. And that means very, very short time constant, expiratory time constant. And time constant is product of compliance and resistance. So even the ventilator here, if you look, tell you expiratory time constant is 0.07. So immediately we can tell that this patient is having um, a restrictive lung process. And the other cases eventually we'll talk about obstructive lung disease like COPD or asthma and see how we can differentiate it from here. This is the tidal volume and this is the end tidal CO2. So we put him on generic ventilator settings. This patient is male, ideal body weight 65 kilograms. So first we put him on the mode controlled mandatory ventilation volume control. Start rate of 15, inspiratory time 1 second. Some ventilators make you choose the inspiratory time versus other you have to choose the flow rate. We put him on the constant or the square flow rate. We put the tidal volume for 100, which low tidal ventilation, about 6 milliliter per kg, and we started with PEEP of 5 and 100% Fi2. So if you look here, the oxygen saturation is 65%, very low, and tidal CO2 is 70, very high. And we get all used like faced to this with this problem. So how we're gonna try to improve the oxygenation in that person? I guess we can all agree, or most of us will will start going up on the peep. The question, of course, is how much, what's the adequate peep, without raising much more on the pressures. But I just want to show you something. Since the patient is on volume control and 65%, what happens if we just, without changing much, will try to get the same tidal volume, same respiratory rate, same inspiratory time, just by switching him to pressure control. Let's see what happens. So we'll put on pressure control ventilation. We'll start with a rate of 15, peep of 5, inspiratory time also 1 second. The ventilator told us 36 centimeters, so let's see how much tidal volume that would be. So of course now you can tell that this is pressure controlled ventilation because the airway pressure looks square. The flow looks decelerating flow. We started at 36 and the tidal volume is about 320, so less than what we need to get the 400, so we'll have to go up on the pressure. And again, we can all agree that those are very high airway pressures and very high driving pressures, unacceptable really. I just want to show you the comparison between the volume control and the pressure control, what will happen just by simply switching the mode. Okay, the tidal volume is going up, so I'm trying to go down again on the pressure to get equivalent tidal volume. We'll take a couple of breaths for the ventilator to adjust to the tidal volume. You can see here that the oxygen saturation actually improved a little bit. You can tell me that the tidal volume is higher, so we'll see what once we get down to 400 what will happen. Okay, we're still above the 400. In any case, while the ventilator is still trying to get the tidal volume, simply switching the patient to pressure control, even with the same tidal volume, same inspiratory time and respiratory rate, minute ventilation, everything, the mean airway pressure is higher in pressure control, and that by itself will improve the oxygenation a little bit. So let's talk about how we gonna, first of all, we need to know more about the patient, what's our compliance and what's our resistance. And new generation ventilators, if you look at the monitor, they already tell you resistance is 10, compliance is about 12, so very poor compliance. But let's measure it ourselves. So we'll go back to the volume control. That patient is passive, constant flow. And sorry, that module doesn't let me do an inspiratory hold, so I'm just gonna put a little pause here so we can measure the peak and the plateau pressure. So if you can see here, we know that our peak is 47, the plateau pressures are the plateau pressure is 44, tidal volume is 400, there's no auto peep, so the compliance basically will be 400 over the plateau 45 or 44 minus the peep, so 400 over 40, which gives you about compliance of 10, very close to what the ventilator said. As for the resistance, the peak again is 65, the plateau was 45, so that's a difference of 20 over the inspiratory flow of 60. So actually the resistance basically peak minus plateau over the inspiratory flow. Just make sure what is the inspiratory flow. It's 24, so the resistance is higher than that. All right, now again, so we know that the patient has pretty poor compliance and resistance a little bit higher, but within the acceptable range for ARDS. So one of the things that I like to do to adjust the PEEP is using the pressure volume tool or the pressure volume curve to see exactly where's our lower inflection point, higher inflection point, the hysteresis. So we'll do this maneuver here. Basically, it will be very slow inflation of the pressure and recording at the same time the tidal volume. We'll wait until the maneuver goes. I try to do it with a little bit slower pressure, or other ventilator you can adjust the flow. You need the flow very low, at like 5 or 7 liters per minute. Always you need the constant flow. So here our ventilator, we'll use the cursor. So while here we started from our peep of 5 here, as you can see the ventilator is giving pressure with no much volume at all, and even the ventilator put for you that red point here, which is above the low inflection point, where it changes from very poor compliance to linear compliance, like best compliance. Then you can see poor compliance again. So the goal is to ventilate the lung on that steep or linear compliance. So based on this, at least on the low inflection point, it's about 18 here. You probably should set the PEEP at 18. Some other people say this is inspiratory, the PEEP is an expiratory phenomena. So where the lungs start the volume, let's go in the expiratory curve, and where the lungs start to lose the volume, that's where we should set the PEEP. And here we're like about almost like 19, so very close. We call it the point of maximum curvature. Some other people look at the hysteresis, basically the point between the inspiratory part and the inspiratory limb and the expiratory limb, where it's widest. And like about here, that's where you can see the much bigger difference in the volume. And here the ventilator tells us in the inspiratory limb is 234, expiratory limb is 1300, so that's like about 1100. If you notice, if we go say PEEP of let's go to 10, for example, of PEEP, the difference will be the hysteresis is almost the same. But so anyway, there's so many ways of setting the PEEP, but that's one part of it. And of course, not every person is PEEP responsive, so you have to be careful with this. Okay, so we're gonna exit. We'll exit this curve. So this is our patient, and again we increase the PEEP to 18 with the same rate, same tidal volume, and you can see because that patient is or was PEEP responsive. Matter of fact, the peak inspiratory pressure went down because now the compliance improved. As we can see here, the compliance now is 20 versus he was 10 if you look before. So he was PEEP responsive, and again, if you remember that pressure volume curve, it looks like the patient would be PEEP responsive given the wide hysteresis. His oxygen saturation improved, but again, we're still using very high plateau pressure. Where's the plateau pressure here? Yeah, 24. But let's go. So that's one of the things that we can do. What happens if that patient's still hypoxic despite increasing the PEEP? Or let's talk about what other method we can do to set the PEEP. So one of the options is to put an esophageal balloon to monitor the esophageal pressure as surrogate for the pleural pressure, and measure the transpulmonary pressure. So again, we're gonna start at where we were at PEEP of 5. There's a lot of people would just use the PEEP FiO2 table. I try to really not do that, because just do personalized ventilation. Not all the lungs are the same, so I want to see if the patient will benefit from PEEP, or I'm just raising the PEEP with just causing over distension and lung injury. Because not all the lungs are the same. Some are PEEP responsive, some are not. So you have to be mindful for this. So we put an esophageal pressure balloon manometry here. As you can see, the end inspiratory pressure, esophageal pressure is 16.6. The end transpulmonary pressure is 23. And what that transpulmonary pressure is basically the airway pressure minus the pleural pressure. So the ventilator gives you the graph for that curve. If we look at the end expiratory pleural pressure, here is 13. We have a PEEP of 5. So if you look here, the end expiratory transpulmonary pressure is about -8. And there were some studies were done basically to adjust the PEEP according to the end expiratory transpulmonary pressure to try to keep it in the positive above 0. And the reason for this, to keep the alveolar pressure higher from inside the alveoli, higher than the forces from outside of the alveoli, basically the pleural pressure, to prevent its collapse. So again, this is our patient. He's getting tidal volume of 420, his saturation is 77. So based on this, I will increase the PEEP. Let's go to 14 to keep that end expiratory transpulmonary pressure above 0. And again, if the patient is responsive, his oxygen saturation should start to improve. If the compliance, if the PEEP improved the compliance, of course the tidal volume now we're going to be much higher, as you can see here. So that's a patient who's PEEP responsive, and it's beautiful when this happens, because now after we're using 35 centimeter pressure to get 420 or 400, now the tidal volume is 720. So I can actually start weaning down that driving pressure to a safer pressure, of course. I'm gonna try to keep that end expiratory transpulmonary pressure about 1 or 2. So here we're becoming about 1.7. Again, the oxygen saturation is improving. Okay, what if those are failing? What else can we do to the patient? At least with mechanical ventilation, before talking about other stuff like proning or pulmonary vasodilators. I want to use like Aprv. Aprv, we have a video for Aprv separately, so I'm not going to go into much in details, but we know that that patient has very poor compliance. So let's start with the settings. T high, which is the inspiratory time, 5.7, 0.3. Let's start with a P high of 20. I start usually P low of 0. Again, those are just generic for now, until we see what will happen with the patient. So you can see here it will be very prolonged inspiratory time and very quick short T low. That patient again is passive, so that's why you don't see any spontaneous flow. Usually in Aprv you want to have the patient having some inspiratory effort to get like about 20-30% of the minute ventilation, but that module doesn't let the patient be active. And you can see like the oxygen saturation is going up again slowly. The release volume is 319, and again we of course if you lower this more, the release, the T low, the release volume will gonna drop. If you increase it, make it longer, your release volume will be higher, but on the expense is if it's long enough, like high T low, the airway pressure might cause, might be, go back to the atmospheric if you make it very high, to the point is you collapse the alveoli. Let's see if the ventilator gonna let me do an expiratory pause. It did, but not a good one. We published a paper before about how to set the T low according to the esophageal pressure and transpulmonary pressure. And basically we keep shortening the T low, the same as I talked before, to try to get transpulmonary pressure and expiratory with the pause above 0. So let's try this again. Okay, here you can see still our end expiratory transpulmonary pressure is minus 20, and the reason is because of course we're using actually low pressure. Remember, the patient on the pressure control required about 36. So if we increase the pressure a little bit, that will, let's do it again. We'll do it. Okay, and now we can see here we did the pause, so the expiratory pressure is 12.8, meaning that that patient is almost at 12.8 of PEEP. Remember, we put the P low 0, but because of very short T low, the airway pressure, sorry, the alveolar pressure does not really reach the atmospheric pressure. And here the transpulmonary pressure after the pause is about minus 1.1. The oxygen saturation improved. Of course, you can do all these PEEP maneuvers on any other mode. Here you can use Aprv, DuoPAP, ASV. Of course, we have a video for this too. And again, you're gonna adjust the PEEP accordingly in the same manner. So the prone position has a really very important role in ARDS, and unfortunately we think of proning once patient become refractory hypoxic and none of our ventilator strategies are working, so use it as a rescue therapy. In the past, proning didn't show improved mortality, so there was resistance to it for the fear of complications. But it always showed consistently improved oxygenation. Over the last 10 years, we've been having more and more evidence of improved survival using the prone position, especially now with the COVID. A lot of people start using proning more. My point is, we should not use prone position only as last ditch effort. We should probably use it a little bit earlier when the lung is still recruitable. And some authors suggest that once your FI2 is still 60-70%, your PEEP is going up, not very high, but like 13, 14 or something, you should think of proning. Don't wait until the patient is 100% and 20, 25 of PEEP, and before do the proning and wait for 5-6 days. So do it earlier. We all know the benefits of proning. We know that the lung is very heterogeneous, and what proning does is actually make the alveolar units more homogeneous. One of the other benefits is, of course, the ventilation perfusion matching. One of the other benefits is the weight of the heart is reduced on those dorsal collapsed alveoli. Some other benefits is the improved pulmonary pressures and the right ventricular function, maybe change in the respiratory compliance of the whole system. So, and again, please read about it, or maybe we'll try to make a video about it. But proning is very important, and most of the studies showed in moderate to severe ARDS, the proning does improve mortality. The complications is really not that high. Everybody gets worried about the pressure ulcers, which can really be dealt with or prevented. The dislodging of the artificial airways, but again, a lot of studies showing that it's not different than the supine position. So it's proning is really important. There is a role for inhaled pulmonary vasodilators, and over the years this kind of fell out of favor, although it's still been tried. Um, the inhaled pulmonary vasodilators that we have is the nitric oxide and the prostacyclins, and what do they do is basically, as their name is, they dilate the pulmonary vessels, so they might improve the VQ mismatch and the dead space. So they might improve oxygenation. Of course, they have side effects, but to my knowledge, there is no studies that showed that inhaled pulmonary vasodilators really improve mortality. How about the role of steroids in ARDS? And this has been extensively studied. Um, High dose of steroids, usually 1 to 2 milligram per kilogram per day, and most of the studies showed improved oxygenation, which is for me is important, so you don't have to give the patient always very high FiO2 and the risk of oxygen toxicity, but also most of them showed no mortality benefit in ARDS. In the recent COVID pandemic crisis, steroids have showed to have mortality benefits in COVID-19. The most important, not the most important, but important is we always get worried about steroids, whether it's in septic shock or ARDS, that it might cause worsening infectious process and nosocomial infections. And there is no evidence really that those short course steroids for a week or 2 weeks worsen mortality or worsen infectious process. And when everything else fails, of course, the only choice left is ECMO, extracorporeal membrane oxygenation. And it's like dialysis catheter pulling from the vein into the pump to an oxygenator and CO2 removal, putting the blood back into the arterial system. The problem with ECMO, of course, it's not in every institution. Sometimes it's very hard to transfer an unstable patient in bad shock and bad ARDS in an ambulance or a helicopter to an institution that has ECMO. That's number one. Number two, depends on who you talk to or how do you interpret the results of the studies. The question is, does ECMO improve mortality? There's really, maybe the evidence is growing, but it's not very convincing that ECMO compared to mechanical ventilation does improve mortality. But of course, if somebody is failing on all the strategies that you do, and ECMO could be life-saving. The other important issue with the ECMO is the ventilator management during ECMO. And you hear a lot of people talking about resting the lung, which really the lung does not rest. So they put a severely injured lung on very low PEEP and very low driving pressure. And basically what we're doing is promoting ventilator-induced lung injury. So management of ECMO is an important topic that's hard to discuss right now. Let's go back to our patient after he did the operation, and we improved his oxygenation by whether it's proning or PEEP or recruitment, whatever we did. And now the patient's stable but still have here low respiratory compliance. So how do we know if the patient is improving or not? Because we know that X-rays lag behind and they're not specific. Arterial blood gas is also still the same. So we need to look for our respiratory mechanics as we talked before. This is a patient right now who's an ASV 125%, who's still in PEEP of 15, and FI2 is 50. So the patient initially was passive, like right now he is passive. What will happen if the patient start to be active You decrease the sedation a little bit, the patient is waking up, and once the patient has some spontaneous effort, the PMOS, he will contribute to the tidal volume according to the alveolar gas, equation of motion. Now the PMOS with the P vent. So sometimes once the patient having some effort, the tidal volume will start to go up, whether especially if it's in a pressure controlled mode, even like ASV or regular pressure controlled, or PRVC. If you can notice here, once the patient increase effort, tidal volume will be higher and the dynamic compliance will be higher. But we can be fooled because of that, and thinking, oh, the patient is improving. He's still same patient in ARDS. He's just his PMOS is he's working hard, and the harder he work, you'll notice here that the tidal volume will start going up. Some modes are responsive, like the ASV, but some other modes, like the PRVC, what it would do is will interpret as the patient compliance is improving and will start coming down on the driving pressure and shift shift the work from the ventilator to the patient. Again, so we need to know so it's very important to try to quantify the PMOS. You can do that with an esophageal balloon, or there's something called P0.1, multiple other ways. Or if the patient is just improving because his compliance is improving and the ARDS is resolving. So right now I'm decreasing the patient effort and improving the respiratory compliance. So the more the compliance start to improve, also the same, you would see like the tidal volume is improving, and now do we still need the say for example the 15 of PEEP? So we can do again the pressure volume curve, you can look something called stress index, multiple other ways. But the more basically you can even do decremental PEEP, and when you go down on the PEEP and the tidal volume start to improve, it means okay, you're trying to get the optimal PEEP. So this is basically like slowly by slowly how we're decreasing the ventilator work as the patient is improving. And of course finally, once we are in lower PEEP levels and the patient is improving, we can start doing the SBT and talk about weaning, and we'll try to do that in another video. But it's again important to continue monitoring the patient to see, are we going in the right direction, compliance is improving, or should we reduce the PEEP? Not because he required a PEEP of 18 yesterday or even 4 or 5 hours ago, it means that his patient still PEEP of 18. It might be 14, it might be 20. So really important to keep an eye on those patients. We'll end here. I want to say thank you, and if you have any questions or comments, you can post it on YouTube. We'll try to reply as soon as possible. Thank you again.